webinar brings together pioneers whose vision, dedication, and leadership have played a defining role in the specialties of infectious diseases and clinical microbiology. From tackling emerging infectious diseases, combating antimicrobial resistance, strengthening antimicrobial stewardship, and advancing research and education. This evening, we will explore the evolution of infectious diseases as a specialty, reflect on the experiences of our panelists, and discuss the opportunities and challenges that lie ahead. From AMR to AI, career opportunities, professional recognition, and the skills needed for the next decade. Our discussion will explore the future direction of the specialty. It is now my privilege to introduce our distinguished panelists. We have Dr. O.C. Abraham, Professor of Medicine, Christian Medical College, Vellore. We have Dr. Ram Gopalakrishnan, Senior Consultant, Institute of Infectious Diseases, Apollo Hospitals, Chennai. We have Dr. George M. Verghese, Professor and Head at the Department of Infectious Diseases, CMC, Vellore. Dr. Dilip Matai, Dean and Professor of ID, Apollo Institute of Medical Sciences and Research, Hyderabad. Dr. Sunita Reddy, Infectious Diseases Specialist, Apollo Hospitals, Hyderabad. Dr. Balaji Veeraraghavan, Professor at the Department of Microbiology, Christian Medical College, Vellore. Dr. Tanu Singhal, Consultant Pediatrics and Infectious Diseases at Kokila Ben Durubai Ambani Hospital and Medical Research Institute, Mumbai. And Dr. Vasant Nagwekar, Director, Department of Infectious Diseases at Sir H.N. Reliance Foundation Hospital, Mumbai. On behalf of the Trust, I extend a warm welcome to each one of you. We are honored to have you with us today. So to lead us through today's discussion, I am pleased to introduce our moderators, Dr. Abdul Ghafoor, the Managing Trustee of the AMR Declaration Trust, and Dr. Ashwini Tayade, Trustee of the AMR Declaration Trust. With that, I now hand over the session to Dr. Abdul Ghafoor.
Thank you, Deborah. Good evening and welcome all, and welcome to the Icons of Infectious Disease, Life Lessons for the Next Generation. This evening, we have the privilege of listening to real pioneers who chose infectious disease and microbiology when the professional path was less defined than it is today. They built departments, trained generations, strengthened antimicrobial stewardship, and helped shape India's response to antimicrobial resistance. And this conversation will look honestly at where the profession came from and where it stands today, and where it may be heading over the next 10 years. We will discuss career opportunities, employment, economic realities of a largely cognitive specialty, and changing role of microbiology, and both the opportunities and threats created by artificial intelligence. And most importantly, we will ask what young professionals must do now to ensure that the specialty remains relevant, respected, and rewarding. India has several icons of infectious disease and clinical microbiology whose contributions have been equally important. We invited several of them to participate in this program. However, because of the very short notice and there were previous commitment, not all of them could join us today. This is therefore not intended to be the only conversation. The AMR Declaration Trust plans to organize follow-up meetings on the different strategic challenges facing our profession, with the participation of many more of these distinguished pioneers. And then we will start the discussion. Professor Dilip Matai, you are one of the senior most infectious disease physicians in the country. When you chose infectious diseases or infectious diseases 30 years ago or more than that, what was the professional landscape in India? How was the specialty viewed by colleagues, hospital administrators, trainees, and families?
Yeah. Thank you, Dr. Ghafoor, and thank the organizers at the AMR Trust for hosting this. I want to cut short all of the introductory remarks of mine, but specific to your question, yes, I'm the senior most. I am reaching 75. So I began my career here in Christian Medical College in 1981 after graduating, finishing my MD General Medicine. At that time, most of the specialties were breaking out. Nephrology was breaking out from my medical. Endocrinology was breaking out slowly. Hematology was breaking out. Gastroenterology was breaking out. Cardiology, neurology, and other specialties were already out. So the question was, most of these super specialists came from the Department of Medicine. Now I was left there. I was happy, or I was join them, move along with them. But then my passion was I wanted to be in internal medicine. In other words, I wanted to be first and foremost a physician. I have achieved that goal from the age of 13. I wanted to be a doctor, a physician, and when in 1981 I achieved that status. I didn't want to move out of medicine. But then what really happened was next door to next door to my department was Professor G.V. Sheed, who was a pioneer, who was a good surgeon, but he introduced hospital infection control to me at a very young age. I was not interested. Then came another opportunity when they put me in charge of making the hospital clean, bandicoots, mongooses, birds, and other things. So that was the second opportunity that I got. Still didn't want to move out because I was fascinated and I was interested in internal medicine, tropical medicine, and tuberculosis at that time. Then when what really happened? I did not have the ability to say no. Rather, one of my personal attributes is that I say yes to everything and then land into trouble. So what happened was I got into these aspects of the hospital infection control in a very, and as an attribute that I could not say no. I just entered it. The second part of it, honestly, you might not all say that my IPR is very good, interpersonal relationship. So when I say my IPR is good, that means I found I could interact with any person, and that is that is something that is required. I thought that was a very good skill or attribute of mine. The third one was I was interested in microbiology and I was interested in pharmacology. So putting all these together, then I thought perhaps all these converged into one discipline, which is infectious disease. So that is how it shaped my career to move into infectious disease. The next one was I was interested in obtaining training. But situations were such that I couldn't get a training spot. So I started writing to all the editors of the textbook of infectious disease. Hoprick, if you remember, there was a textbook. I started writing to all of them. I wrote to Sidney M. Feingold, who was the editor of the journal at that time. I wrote to Sherwood Goback, who was in Tufts. I wrote to John Bartlett he later moved to Johns Hopkins and then to Dr. Haragopal Tadapalli. All of them moved out from Cook County. This was somewhere in the 88, 89. HIV has just broken out in California around 85, 86. So I used to send them my birthday card also, telling them I'm still alive. Could you give me a training opportunity? So finally, I received a training opportunity in 88, sometime in 89, 90, I received that training. So I spent 2 years as a fellowship research scientist. But at that time, I was interested in laboratory medicine. I spent a lot of time in laboratory medicine, in the microbiology lab, in the vivarium, in the anaerobic lab at API at Virginia. A lot of my exposure was in the microbiology lab. I think it helped build my passion or love for the subject of clinical microbiology. Even with later on in the University of Iowa, I was with Dr. Ronald Jones. I played around with E-strips and I played around with ribotyping, pulse field, all in the laboratory. And then I had an opportunity to work with Dick, that is Wenzel. Dick, he was there at the University of Iowa and looked into the aspects of hospital epidemiology, then got a Shea Fellowship, then got an HIV training fellowship. All these helped me build my passion and helped me develop. And finally, I had no conventional training, like in the classical sense of a boards person or a DM person who's currently undergoing. All these helped me. And then I moved into, and I came back to the country. Now the most difficult part, building the specialty. I had fears, I had failures, but that's a given. That's nothing to be concerned about. Because you're coming back and you don't know, I was a good physician. Am I moving into something, a new territory? I cannot come back to this place? Will people follow me? Will I have a ability to develop? The fears were, and internal medicine was not allowing the breakout of infectious disease because the API people said, what is it, what is left for us? All the specialties goes out, in diabetes has gone out, in endocrinology, there's nothing left for us. So there was a fear complex at that time, what would really happen? Yes, tropical medicine was available, etc. But hospital epidemiology and hospital infection control belonged more in the realm of the microbiologists. But I had very good role models. Dr. Jacob John, Dr. Lalita, within my institution, outside my institution. I had Camila Rodriguez, Ajita Mehta, and Ayagiri at Lucknow SGPGI. All these people played a significant role in my personal development as well as helping develop the Department of Infectious Disease at CMC Vellore. Then next came in collaborations. I was, like I told you, my IPR is good. I built a good relationship with several corporate entities, and they financed me. Sipla Hamid Bhai, he financed me with the AMR laboratory here. When I trained in the US, I had no intention of getting into HIV/AIDS training because I told myself, and I told them, my chief also, so HIV is not going to come into my country. We've got other bigger problems. So I was fortunate to work with antimicrobials, both with Ron Jones, with Tadapalli, never, and a little bit of fungal work which we did in the University of Iowa. But by and large, I had good hands-on microbiological skills and field epidemiological skills participating with the public health. So all these gave me confidence that I can manage, and I'm hoping that my successors who follow me would also manage. So that is how I got into it. So I'll just stop here and then we'll take up further questions. Thank you.
Thank you, Professor Dilip. And that's a very interesting recap of how the infectious disease specialty was born in India, a combination of all specialties with a very good IPR. OC, what were the most difficult barriers you personally encountered while establishing yourself and the specialty?
Well, I was part of Dr. Dilip. Dr. Dilip Mata is my mentor and my teacher in infectious diseases. So he had already established the groundwork, laid the foundations for me, and he found a training opportunity for me also. I trained with Professor Chandrasekhar at Wayne State. So there were no major barriers. The barrier was when I came back, infectious diseases was still nascent, still was part of the Department of General Internal Medicine. And we had the biggest clients of ID, the transplant groups. In CMC, it was nephrology and hematology oncology had well-established transplant programs. And they were pioneers. So we had a colleague in nephrology who modified Rubin's calendar of infectious diseases for tropics. Professor Maman Chanti, who was the father of BMT in India, he knew more ID. So it was like, why should we consult others about this one? But once it was for me, the strategy suggested by Professor Chandrasekhar, just shadow them, don't interfere too much, just don't antagonize them in any way, offer consultations, offer opinions, and slowly as they see your value, they will encourage you to come up with a specialty. A couple of other things which happened was the HIV epidemic. CMC was one of the places which opened its doors to PLHIV. NACO needed to train people to roll out the ART program. They came to CMC, set up the training program, and then the fellowship in infectious diseases, which later became the ID. So the ID traditionally was not a separate specialty in India because my teachers were pulmonologists, cardiologists, neurologists, nephrologists. There were no good or very few good microbiology laboratories in the country. People looked at culture reports with a lot of skepticism. Serology was all we had. We didn't have such molecular tests. So lack of good laboratory support. So a lot of diagnosis was empiric. Antibiotic armamentarium was limited. So all these things, ID never became a good specialty. So it's a work of pioneers. In India, there were 5 pioneers, Professor Dilip Mathai in Vellore, Rajiv Soman in Mumbai, Ram Gopalakrishnan and Ram Subramaniam in Chennai, and Dr. George K. Verghese initially in Mangalore and then Bangalore. These were people who got themselves trained, excellent physicians, internists. Those who went abroad came back to India, set up first patient care clinics and inpatient services, then branched off into training, Rajiv in Mumbai, Rams in Chennai, and then CMC Vellore. So that is how ID evolved in India.
Yes. Thank you, OC. Of course, you know, you got a very good advice for your mentor. Don't offend people. Give your advice. They will eventually value your opinion and expertise. Ram, yourself and Ram Subramaniam built the Department of Infectious Disease at Apollo. I joined several years later. By the time I joined, you already built the foundation of infectious diseases. I'm sure both of you have to take a lot of pain to establish the early years of infectious disease at Apollo. How did you demonstrate the value of an infectious disease physician at a time when institutions didn't always even understand the role of an infectious disease physician?
Yeah, as you might imagine, it wasn't easy at the beginning, but as Dr. OC said, if you work with others without antagonizing them over a period of time, you make a good diagnosis, you save a patient who otherwise would not have been saved. You try to avoid treading on other people's areas. For instance, as an ID specialist, I took a conscious decision not to treat other aspects of general medicine. I just fix the ID problem and hand it back to the physician. But what actually made the difference for us here in Apollo was that we had a couple of very sick VIPs who we got better. So that perhaps raised the esteem we both had in the eyes of both the management as well as our colleagues. And after that, it's been no complaints. It's been going good all the way. So one of the take-home messages for youngsters in the audience, if you have a VIP in your hospital, fix that patient's problem and your career is more or less made, at least in your hospital.
Thank you, Ram. Ram, the establishing a specialty in a hospital like Apollo will be different from CMCs. Of course, challenges are different. Both are challenges. We always say we don't like VIPs, but in a corporate setup, when you establish a specialty, treating VIPs, people will recognize the value of a specialty and expert advice. Thank you, Ram, for pointing out that very important point. George, which professional decisions, collaborations, institutional choices, or personal qualities helped you overcome those barriers and establish a meaningful career?
Thank you, Gafur. You have actually stimulated a lot of thoughts going back several years or even decades behind. So when I look back, 3 decisions shaped my career more than anything else. First of all, investing in world-class training. At a time when there was no specialty of infectious diseases or even structured training programs. In India, certainly there was none, very few mentors, but I was fortunate to have been initial role models and mentors, later on in life has been Dr. Dilip and Dr. OC. I was fortunate. But the next important thing which has happened is the training program which I have chosen. Initially, I went to UK, was trained at London School of Tropical Medicine and Hygiene, and also worked as a specialist registrar for 1 year. So this, I realized that, even UK was just beginning to start their infectious disease training program. The whole country had 3 positions for training in infectious diseases for the entire country. They were also just beginning. So by then I had already done my USMLE. And then, of course, with the credibility which Dr. Osi and Dr. Dilip created, my entry into Wayne State was quite easy. And that was one of the best periods in my life, and also the training which I have received. There were about 20 outstanding faculty members, each leader in a different area of infectious disease. From Jack Sobel, clinician par excellence, with expertise in fungal infections, Dr. P.H. Chandrasekhar's expertise in transplant and immunocompromised hosts, MacArthur's work in HIV and antiretroviral therapy. I can go on and on. So the most important thing which shaped my career was investing in one of the world-class training in infectious disease, although we did not have that opportunity in getting trained in India. And the second, of course, was stepping outside of my comfort zone. I will give you an example. During our fellowship, Sunita has been my co-fellow, and she will also tell you, we had to do a research project as part of the fellowship training. At that time, I was already into clinical research. I knew that I could do, or I could take that forward. But I decided to choose a basic science project. I often say that I barely knew how to hold a pipette when I entered the laboratory. What I did during that time was amplifying and sequencing FKS gene, which encodes echinocandin resistance in Candida parapsilosis. At the end of that whole process, I became very confident in molecular biology and many of the laboratory techniques which we use in our practice and also in research. So looking back, it was one of the best decisions I ever made. It enabled me on returning to CMC, establishing ELISA, PCR, and sequencing platforms for scrub typhus on a research project, which actually led to subsequent several translational research and answering several questions which are relevant to us. Third, of course, was choosing the purpose over convenience. I had opportunities to stay back both in the UK and in the US, but I chose to return back to CMC. It was the single most important career decision which I made to come back to CMC. And although the challenges were greater, there were several opportunities to build, the specialty along with my mentors, Dr. Osi and Dr. Dilip, and train future leaders, establish research programs, and create impact that extended beyond my own practice. So looking back, most of the important career decisions were not the safest ones. They were ones that stretched me, challenged me, and allowed me to build something larger than myself.
Thank you, George, and stressing an important point, stepping outside the comfort zone. All our pioneers built a specialty. There is a saying, as you know, go where there is no road and leave a trail. That's why all of you, the pioneers, how you build the specialty. Tanu, what did it take you to build that department, a training program, a stewardship program? What lessons from that experience remain relevant for young professionals today?
So I was very fortunate, to just give you a little bit background about how I became an infectious disease specialist. I was doing pediatrics at All India Institute of Medical Sciences. And there we had this super specialty thing, and everybody was choosing nephrology, endocrine, GI, and I was interested in infectious diseases. But there was no training program in infectious diseases. So I got this opportunity to go and study at the London School of Hygiene and Tropical Medicine. And I did do a master's there, but it was basically something which gave me theoretical knowledge, not practical knowledge. But I was very fortunate to return and join Hinduja Hospital, and where I met my mentors, Dr. Rajiv Soman, Dr. Camilla Rodriguez, and Dr. Ajita Mehta, and we four of us established the Department of Infectious Diseases there. We established the department, and I still remember that Dr. Dastoor told us that if you really want ID to take off as a specialty, then you must focus on teaching, because that is how people will know about infectious diseases. And we started this infectious disease certificate course, and we started it in the year 2004. And that was something which really put infectious disease on India's map, because we got people from all over the country whom we coached, and that course is still running today, and now it has been taken over at Jupiter Hospital. So I think education and lectures helped us grow as infectious disease specialists. So it helped me grow because I learned a lot of things. So in establishing a department, I think that education and lectures really helped. Then the second thing which helped, making a department, when I moved on to Kokila Bain Hospital and to establish credibility, was my active participation in the infection control. Now, I actually see a lot of, junior infectious disease specialists who do not take interest in infection control and antimicrobial stewardship, because they feel it's not very exciting, and they really like to do more clinical medicine. But I think it is a very, very good way to to establish rapport with other clinicians, and also to make yourself known to the management of the hospital, because then the management interacts with you and they see what expertise you bring with you, and it allows you to interact with all clinicians in the hospital, including surgeons, etc. So I feel that in setting up a department of infectious disease, paying sorry.
Carry on, Tanu, carry on.
Yeah, so helping to set up infection control and antimicrobial stewardship is very, very important. So that is the other message which I would like to give. And the third, there is some.
No, your voice is very clear, Tanu.
So these are the things which I felt were important in kind of establishing departments. The first, it helped by setting up certificate courses, etc. And the second is the junior people, they can make their mark. And because sometimes when you start your practice, you don't have a lot of work. You can utilize that time to do infection control, antimicrobial stewardship, etc. And then gradually you kind of build your practice at that time. So I think those things are very important. I think the second part of your session deals with AMS, and I feel all infectious disease specialists have to take a lot of responsibility for AMS. Dr. Ghafoor, you're muted.
Yeah. Am I audible now?
Yes, sir, you are.
Sunita, which achievement gives you the greatest professional satisfaction? And equally, was there any setback or failure that later became an important lesson in your infectious disease career?
No, okay. Good question, Ghafoor. So, it was impressive to hear Dr. Dilip Mehta, Dr. Varghese, in terms of how they started off their career. For me, it was slightly different. when I finished med school, I wanted to be in a place where I had a lot of adrenaline rush. So I wanted to do the surgical fields. Then got married and went to the US. Surgical fields was not an option, landed in internal medicine. It was not necessarily my first choice. But life is that way. You don't decide life a lot of times. Life decides you. So you have to take it as it goes along. Internal medicine, I was doing it. And my favorite subject then and what I wanted to do was critical care. Again, I needed that adrenaline rush. Unfortunately, at that point, I had some personal tragedies in life. And that made me realize that, see, you may want what you want, but you cannot afford to be in a space where time is not in your control. So then I had to change my plans and figure out what to do. And at one point, when Dr. Chandra has been my mentor, like for most of the people in this group, when I met him and in the first 1 or 2 visits that I've had with meetings I had with him, he asked me what I wanted to do. I probably would like to, will apply for nephrology, will apply for rheumatology, will apply for infectious diseases, and live in whichever way I want. I mean, which will be fine with whichever specialty I get in. And the advice he gave me is, please don't tell this when you go for an interview. You're not going to get into the seat then. So anyways, but as I worked with Dr. Chandra, trying to get back my life at that point, I started enjoying infectious diseases, and that's how I landed up. So when you're talking about setbacks or failures, every setback is an opportunity to something new. I wanted to do something, but every time there was something that happens in your life and it takes you to a different path, that does not mean it's a bad thing. It just is an opening to another thing and to another way of life. And you should be content in whatever you do. You should enjoy what you do, and that will take you forward. So today I'm happy with the fact that I landed up in infectious diseases. And we've started a training program. We've built a department. It was not easy to build a department. When I actually came to India and we started working here, I would talk to the administration and say, see, if there are patients with HIV, why don't they ask us to give a referral? If there are patients with, say, a fungal infection like mucor, involve us. That's our specialty. The admin was very clear. We will not give any kind of a support like that because that will antagonize another physician. So with almost that kind of a scenario, today it is like any of the complicated infections, be it mucor or HIV or any of the infections, most of the physicians would come to you. It was a difficult treading path because you didn't want to step on someone else's foot. Particularly the physicians was one group of people we were advised to be even more careful because then you'd be eating into their business. So you should not antagonize them. So like Dr. Ajake said, would never do anything other than only ID. And the other thing that I've learned is when you see a patient that things didn't go right, take that extra effort to go meet say, if somebody has surgical site infection and you think things were not handled well, you go to the particular surgeon or physician, meet him in his room, one-on-one, and explain your point of view. That really makes a huge difference in developing the interpersonal rapport and the respect for each other. Instead of going and telling everybody or bitching around, talking to them straight one-on-one and explain why you think your point of view. And once that person gets better after they implement what you said, that really makes a huge difference in your career as well as professional growth, as well as making friendships in the long run. So whatever trouble that setback is not a setback. It's just a challenge to another new field or new thing that will happen in your life. Don't look at it as a setback.
Thank you, Sunita. As you rightly said, life is full of challenges. That means life is full of opportunities. And I'll go and talk to the people. And Dilip also said IPR, interpersonal relationships. We can't force consultations or opinion for others. We should make others understand our value, and they definitely will ask our opinion. Vasant, you learned from your teachers, and then you yourself is a master now. If you could revisit the first 10 years of your career, what will you change and what will you do exactly the same way? What will you change and what would you do exactly the same way?
You mean to say after I did my ID, before?
Yeah, first 10 years, your combined could be your general medicine career or later ID career. What you want to do it differently and what you want to do the same.
So after I did my ID from Apollo Chennai, and then in 2012 I came back to Mumbai, back to the same hospital where I was practicing as a physician. So the consultants, majority of them did recognize me as a physician only when I came back to Leelavati. But then I started, as Dr. RGK said, I had made a very clear, and I think he had given me, and VRS said, a very clear instruction that when you're going back, you're going to practice only as ID and you're going to drop your general medicine completely. So that's the first change which I made was I stopped looking at all the general medicine references and I was wanting to practice purely ID. So whatever, I was there in Leelavati for good 6-7 years before I went to Apollo Chennai to do my ID. So the same friends started referring the same physicians' references. But I was very clear and I politely and nicely told them that, I'm completely not wanting to do this. So initially they were offended because the same people who used to send me references for fitness, for surgeries and all that, and then they have. But I think over a period of time they understood what I'm trying to do, and I started giving them good results in when it comes to infections and infectious point of view, and I really made that change, and then I was clearly demarcated myself completely from a physician to a completely transformed into ID physician. So that took me good 3-4 years. And once I did that, then I decided that, I should carry on this message and because there were when I did my idea, I think there were hardly total in India would have been not more than 20 or 25 infectious disease consultants, or maybe lesser than this. So I really wanted, meaning I was so much passionate about this subject and I liked it so much. So, and also I found that there's so much of deficiency across Mumbai city itself that I thought or across Maharashtra or India, that I thought the next thing I want to do is start just like how I got trained at Apollo Chennai, I started to wanting to do a fellowship program in Mumbai. So that's what I started in Leelavati, and I think I've been successful in doing this and transformed at HN Reliance the same program. But main thing is that, I want more and more people to have learned this subject in a better way. And so you're going to discuss about antimicrobial stewardship in your next talk, which is the most baffling thing, which is, people not following at all, and which is the most need of in our country with the rising antimicrobial resistance going on. So I think to have a precise, good, another thing was to have good diagnostics in your hospital. So I did convince my, administration to, meaning for having a good ID, we require a good microbiology department, and for having a good, require good diagnostics if you have a good microbiology department. I think that was another change which I made in Leelavati Hospital. My administrator did listen to me, and we had a good diagnostics, and now we are having even a PCR lab in a 300-bedded hospital where we are. So these are some few changes in academics, education, and I've been quite good. I mean, successful in so far doing that.
Thank you, Vasant, and all you pioneers in infectious diseases. You all described how the specialty was built. Now let's see what is the current status of the specialty and especially how AMR changed the visibility of the specialty, at the same time increase the responsibilities and institutional expectations. Over to you, Dilip. My question is, how has the profession changed compared with the early years? Where have the infectious diseases progressed beyond your expectations? And where has progress remained disappointing or incomplete?
Yeah. And now I'm the chairman of the mortality and the morbidity committee of my hospital. I have about 13 to 15 deaths every month. If you look at it, 7 to 8 or 66% are due to sepsis. Now, if you look at the sepsis as the cause, 50% of it is because of late recognition of sepsis, not really AMR, late recognition of sepsis, and not using appropriate therapy, appropriate antibiotic, or taking the high-end antibiotic as an empirical guide to treat the sepsis. So until you begin to understand antibiotic usage in the ER, in the ICU, I'm not worried about ambulatory care settings because that's not, I don't want to get into that. But in the ER and the ICUs and in the hospital wards where AMR plays a very significant role, and that is where an ID specialist can step in. One, for prevention, and two, as Tanu said, education. You cannot win over anybody. Everybody has MBBS, MD, and the license to use antibiotics. You have to reason with them. Anna, kana, whatever you're doing is fine. But can you tell me the name of the organism you're treating? Can you tell me which antibiotic is being used to treat that particular organism that you're treating in a nice way? Yesterday, I had a bad cellulitis of the foot. I told them this organism is only going to be streptococcus. I don't know the name of the organism. You do the blood and see what happens. And I said, start on penicillin or cloxacillin, or you start on cefazolin, whatever you want. I take responsibility. I take the responsibility, and you have to stand by the patient, measure the limb girth for the next 6 hours or the next 24 hours, and show them that it works. Nobody is hand holding the physician. And that guy is out there not knowing what to do because he has to manage the Parkinson's, he has to manage the ischemic heart disease, etc. So you must take, infectious disease guys should take the full brunt and the responsibility to make sure that that infection is curtailed and the patient doesn't die of that. So that is where the current role of AMR, where people have understood that there is a situation called significant multi-drug resistance in the hospital. Newer antibiotics are coming in, and people are not using the newer antibiotics properly. So just to sum it up, the interest in this AMR is that patients die. Patients have to die. There's no reason, there's no way we can prevent that death. But dying of infection, they may have to do, because if it's a bad intractable pneumonia or a pneumonia that produces a refractory hypoxemia, you can't do anything about it. But if you lose a patient with a SOFA score of less than 4, remove your degree. I don't allow somebody to die of a SOFA score less than 4. More than 4, we'll take a chance. Nobody monitors like that. Everybody says escalation is very easy. If the guy dies, my neck is cut. That's not the way you should look at. So in summary, the training of the usage of antibiotic has to improve in the hospitals, and only a learned ID specialist can do so. And if you are going to do so, hold hands with them. Don't just write consultation and move out. Wait till you accompany him to the discharge door of the hospital. That is how I would value the life and role of an infectious disease specialist in any hospital if I am paying for that.
Thank you, Dilip. Now a follow-up question. Is OC there? OC?
Yeah, I'm here.
No, infectious disease physicians and microbiologists have become central to the antimicrobial stewardship and response to AMR. How has this responsibility changed the identity, visibility, and expectations of our profession?
Can you repeat that question? So what are you asking me?
We ID and micro, we are central to the antimicrobial stewardship and AMR response. It's a responsibility, but how has the responsibility changed our identity, visibility, and expectations of our profession?
The interaction with clinical microbiology is a two-way street. It enhances both. ID, like I said in the beginning, why was ID not a prominent specialty when, at least when our generation was in training? Because lack of good diagnostic microbiology laboratories. We didn't know about CLSI or UCAST, and we didn't have automation, we didn't have molecular tests. So now availability of good diagnostic laboratories which insist on quality, I suppose that is integral to the practice of infectious diseases. In CMC, we have this good fortune of an excellent microbiology laboratory with people like Dr. Balaji. We have a two-way interaction. If I have a problem, I can any day pick up the phone and talk to them. I can query them about results which I may find a little surprising. There is no ego involved. And they also, they send their trainees with us to around. So it's a positive, nurturing or enhancing kind of relationship. Antimicrobial resistance has certainly improved the visibility of clinical microbiology, infection control, hospital antibiogram, stewardship activities. All those things have only improved the visibility of clinical microbiology. So it's a two-way street, and you need symbiotic relationship, is, if I may want to put it in a single word.
Thank you, OC. Yes. Now, the AMR, AMSP, infection control, all these have given a better, bigger responsibility. But that doesn't automatically create better jobs or better remuneration. Now, let's examine what is the current employment and economic realities of our profession. Ram, what is the present job market for ID physicians in India? Are these opportunities expanding uniformly or concentrated in select cities, academic centers, and large corporate hospitals?
Yeah, without a doubt, ID is considered a tertiary care specialty concentrated in the centers you mentioned above. What is unfortunate is that there is very uneven distribution. I'll just give you an example of my home state, Tamil Nadu. Tamil Nadu has numerous government medical colleges. In Chennai, we have 4 government medical colleges. None of the government medical colleges have an ID department. They don't even have an ID trained physician. They don't have good microbiology labs which can support tertiary care hospitals that perform transplants, etc. So, on the one hand, in Chennai, if you would see, most of the private sector hospitals would have an ID physician. So it's well stocked because there is a tradition of ID here for the last 20 years or so. But the government sector is actually a big zero. The only hospital which has ID physician is, of course, CMC Vellore, which is which has had a long tradition of ID. So it's very, very uneven, and that needs to be distributed much more evenly. I'm sure the same can be said about other states in India. Yes, we do have an oversupply in certain parts of the country, especially in the private sector, but there is enormous scope for growth, both in smaller tier cities as well as the entire government sector, both central as well as state governments. For instance, my alma mater, PGI Chandigarh, started DM training in ID just about a year or two ago. And my MBBS alma mater, Madras Medical College, doesn't have an ID training program. So there's a lot of scope out there, and so young graduates need not worry that they will not get a job. If they are well trained, they will surely get a job either in the private or the government sector. And as in all specialties, you make your own luck. If you are good, you will be recognized and picked up in either sector.
Thank you, Ram. That's a very good message to the youngsters. Now, just as a follow-up question to George, youngsters sometimes ask, Ram already gave a very good reply to it, but just want your opinion on that. Sometimes youngsters ask, are more training programs and specialists emerge? Are we likely to face an oversupply in some regions or practice settings? How should training capacity be aligned with real employment needs?
Well, Gafur, when we started the training programs in India around 2010, we had two national board training positions for the entire country, and then eventually CMC, Hinduja, Apollo Chennai. Of course, they had the national board programs with very few number of training programs across the country. Now moving to several medical colleges offering DM in infectious disease has been one of the biggest achievements, I would say. If you look at maybe around 2010, around that time, all we had was about 20 ID physicians across the country. And today, probably we are trained ID physicians are at least 200 across the country, 10 times that we had earlier. So we have actually made significant progress. But one of the most important thing or the challenge which we will have in terms of training is to give quality training in all our trainees. I think that will be the challenge. If you specifically refer to the AMR situation, is if you earlier people used to ask which antibiotic should I prescribe. Now there is a culture that the question we managed to change the question to certain extent. Now the question is little more like how do we make the diagnosis and how do we prescribe the antibiotic appropriately. That change in the approach of making a diagnosis and prescribing appropriate antibiotic. So our success will be in maintaining a good quality, training good quality ID physicians across the country. In terms of numbers, I think we have done reasonably well in the past 10 years, but we need to do a lot more in keeping that quality to the extent what we would like it to be.
Good. George, now Sunita and all of you, now we the private doctors, the corporate doctors, the income disadvantage of a cognitive specialty. Because in most private hospitals, infectious diseases is among the lower income medical specialties because it's predominantly cognitive and doesn't generate procedure-based revenues. How serious is this disadvantage and how does it affect recruitment, retention, and willingness of talented young doctors to choose the field? The important question of remuneration.
I think this is one question that runs into the mind of every student that is applying for an infectious disease fellowship program. But if you look at it, it is kind of, if you look, it's similar to the internal medicine, which is a cognitive field where you're not doing too many procedures in that way. Will you make enough money to have a comfortable living, whatever you do? I think that is not even a question. It's only when you start comparing with the procedure-related fields, then that disparity will be noticed. But are you going to be happy with with the work that you're doing? Absolutely. And if you do want to get into, infectious disease is actually, I would consider it as a stepping stone for other areas also in terms of opportunities. say if you want to get into administration, who better than an ID physician who can get into admin program? If you do if you do wish to get into admin, maybe even do a MBA and get into administration, you can run a hospital, you can do a lot of things other than just patient care, because you have the exposure of public health, you have the exposure of antimicrobial stewardship, you have the exposure of infection control. So much of exposure no other person in the field will have. And ID is the only field which actually connects to every other department in the hospital. No other subspecialty will connect to the others, all other departments in the hospital. So if you want to extend beyond the scope of just clinical practice, there is plenty of scope, and if to work on and do more than what you're doing. And if you really want to make money, even then there is options in terms of setting up a business of medicine, in terms of setting up outpatient OPAT therapies and so on. You can get into the pharma industry and work with the pharma industry. And there is no end to what you can do, actually. Dr. Dilip is wanting to add some points.
If I am permitted, because I have the experience of the corporate sector as well as a teaching institution. When I was professor of medicine, I don't know at that time what it was, but today the salary for a professor of medicine is 2.50 period. Now, if I have to employ the same person's skills 12 years after his MD or DM and he becomes professor, I will pay him in a corporate hospital 3 lakhs or 3.5 lakhs as such. That's a good pay for an ID physician. But he or she will have to return the money to me. I need 8 times the revenue. How is the ID person going to give me 8 times the revenue? I am not asking for my salary back. I want 8 times 25 lakhs revenue. You don't have any gimmicks. You have to work hard. Can you see 25 consults per day, which will give you 25,000 rupees a day for me? Can you generate 25,000 or 1 lakh worth of investigations? Then you're in my ball game. If not, contribute to my outpatient care, see patients, and try to generate revenue by admitting them. Infectious disease doesn't have any more long-term chronic cases. Osteomyelitis, bacterial endocarditis could come under you or could come under the specialty of orthopedics or cardiology. So you have to generate business. You must build your business. Now, I am equal to each one of you today. I'm a nobody, 75 years, and National Board will not allow me to continue as faculty or dean of the academic medical college as such, period. I am going to work like this. I'm going to generate my income. I'm going to generate food for my stomach. I have no more responsibilities to generate income for other people. I am a one-man show. So when you youngsters get into the field of infectious disease, please make a choice. I want money. Show me the money. Then you take up a specialty. Infectious disease, there's no money because unless you work for 10 years, you cannot be recognized as a good consultant. You have to be in a same institution. You don't jump from one institution to the other. If you do, you have to build a new ecosystem. So please understand this. There is money, there is work, there is ability to generate income. This packages system has made some difference, because if you get into the package of a transplant guy or a 25 lakhs or 50 lakhs for a liver transplant, or if you get into the package of a heart transplant, it's all 50 lakhs and 1 crore. How much are you asking for? Measly 1 lakh to control infections in them? They won't even look at you. Come along, come along. But please show your worth. You have to show your value. Dress properly. Go out there and impress people. When you see a consultation, show them the consultation reference. None of that we are doing. We are not promoting our service. We are saying, Macha, I will do this for you, do this for you. Hold hands with them. Money is there. I'll take you.
Yeah. Professor Dilip was in CMC earlier, as we all know. And now Professor Dilip is a corporate doctor. So of course, he knows the value of the money. Now Ashwini, we are promoting you from a moderator to a panelist. What is your comment on this financial part?
Oh,
enough? Because
whom are you asking? Me?
Yeah, no, Ashwini,
Okay. Sorry.
Ashwini, many of the orthopedicians, oncologists, neurosurgeons get 10 times and even 20 times my salary. And I believe I'm doing an amazing job controlling infections, antibiotic stewardship. I always claim without infection disease, no specialty can practice. But I'm not getting paid. What do you think, Ashwini? How can we change the scenario?
I don't think financially we can do much because this discrepancy or this difference is going to be there. You manage a PGI joint infection, the orthopedician will earn in lakhs and you will earn in thousands. So that difference is going to be there. But then you are the one who is going to make the difference by giving appropriate antibiotic or appropriate suggestions. I used to think the same when I entered Nagpur, and my fellow colleagues from other specialty, nephrologist and other, they grew in 2-3 years, and it took me a decade to establish specialty. I don't think I can go to financial extent what they have achieved. So practically, I feel the difference is going to be there, and that is a challenge ID is facing. So like who said, Sunita ma'am said, going to admin, having your own setup like I did. So probably something like that can fetch you money. Definitely the setup was not for money. It was for establishing ID as a specialty and getting more recognition for ID. But I think going out of the box can help grow ID financially. Otherwise, I don't find any money in ID.
Tanu?
Yeah. So I think there is no end to comparison because you can compare yourself with the gastroenterologist or the pulmonologist, and they can compare themselves with the surgeons who can in turn compare themselves with somebody else. So this thing of comparison will never end. So I guess if a sub person is opting for ID, he should understand that yes, this is the amount of money he is going to earn, but there will be other satisfactions which he is going to get, which is quite considerable in making a difference in the outcome of the patient, and being able to. So, what are the other benefits? Like to be able to interact with other specialities, to be able to practice as an internist, like Dr. Dilip Mathai was saying, that, like other specialities, they just become like they have a tunnel vision, whereas an ID specialist does not have a tunnel vision. They have a very broad vision. So they should understand that these are the other benefits, and I'm sure there will be people who will be happy with these kind of benefits and not look at the money. And because otherwise, if you want to earn money, why would you be a doctor? You would like to do something else. So I'm sure there are people out there who are not looking at it just as a money making exercise, and they would be happy to take this branch and be happy with the remuneration they get and not constantly compare themselves with other people.
First Vasant, then George. Vasant?
So I have a slight difference of opinion from what has been said. I feel ID is a branch which generates a lot of money for the hospital. Actually, the administrations are turning blind to all of us. That's the reality. Actually, ID makes the hospital earn so much money in diagnostics. You teach all your colleagues, orthopedics or ENT, your whatever colleagues, you ICU, critical care physician, you teach them correctly to how to use the diagnostics. You make them teach the different high-end diagnostic like your biofires, your PCR labs, and so blood cultures. I remember in Fortis Mulund when I joined, only 60% of the people used to send blood cultures 2 sets. By the time we kept on training on antibiotic stewardship, we made it 100% of the people who start antibiotic will be sending blood cultures. So you're training them, not only your students, but you train each and every specialty, because ID is a very, very broad specialty, right from head to toe, rather than every other specialty has got a very narrow tunnel vision. And even that tunnel vision also is a big question mark in that understanding the ID part of that. So I think for me, I think ID, of course, the administration does turn blind because they are not understanding. But if you go to see the diagnostics, what ID helps in generating or developing the microbiology lab to bring in new tests And because you bring in new tests, you're going to definitely charge more to the patients, and all these diagnostics are going to be used, whether it's a imaging or whether it's micro. But I think the most important is microbiology, and I think you train your colleagues also to do things correctly, and I think it definitely
No.
generates indirectly.
No, so but it generates money for them, but that money will not flow to the ID specialist.
ID specialist, I'm saying ID should be paid more because the hospital administration feels that ID is not of, because they just see the patients, they don't have any procedures, but all these are indirect procedures. You're directing all the people in your mic. Tell me, Danu, how many, I mean, are you not?
But that indirect money doesn't come to ID pocket.
Yes.
No, it doesn't
And
come to
even
ID
if
pocket,
you,
but what I'm saying is
It's
the
just the
the
recognition
administration.
and the edge you get, I guess. So that is
But
definitely
I think over a period of time, people will learn ki, the ID, of course, ID is not generating money for the ID physician, but ID is definitely generating a lot of money for the hospital, which they are turning blind to it, which they have to realize, and they'll realize in a period of time.
No.
probably webinars like this, we should involve the management people.
No, ID does not earn for my hospital, period. We lost out. If you ask me what's wrong with our profession, we lost out. We lost the patient. We don't have control of the patient. Unless and until ID starts admitting patients and call the nephrologist, call the respiratory, call the cardiologist. Why are you not doing that? Go call the geriatrician if you want to. You have lost you have got autonomy, and you're not accountable. You must have patients under you. Call the others. I will show you money flowing in. And I am also taking, and please understand valuation and free cash flow. When you look at valuation of a hospital, if I have more than 100 specialists within me, my value of the hospital goes up. It is the valuation in the hospital of today in India is skewed. You have a PE ratio and cannot support such a valuation. Whereas if you have free cash flow, none of these hospitals, let me name it publicly, none of these hospitals out there in Chennai city are making money, though they charge very high because they are invested funds. The free cash flow is not there. There is no net operating margin. Having said that, you go into a system where you charge, you admit patients, and you say, sir, I brought in 10 patients last month. My total contribution length of stay was 4 days into 40 days. I've earned you 6,000 rupees per day. Can you give me a 10% salary? You take risk. Don't say, I want a fixed salary. If you have fixed salary, my blood is boiling. I have to pay you end of the month. So you try to change yourself. I will show you what I mean next 15 years later, next 15 years, if I make or break it. I am now going through a problem with my wife because she doesn't want me to invest any money into what I want to do, crazy thoughts I have. But one day I will show you that's the way for ID to go forward. I am getting myself involved in multiple hospitals to help their ID program. So I don't need money for my bread and butter. But I want to see the challenge if I can be entrepreneurial and clear it only through ID practice. That is the challenge for you. If I can do it at 75 and go bankrupt, why can't you start at least and keep trying? Take it. I'll be with you.
I switch sides, he's a big administrator now. How you ID people are not generating income for us. So to give an answer, I'm promoting myself from a moderator to a panelist for 2 minutes. Dilip ji, without infectious disease, infection control, ICU cannot run, theater cannot run. You will not get NABH accreditation. You have to close down the hospital.
Very good.
Very important for the money point of view, but we are not paid. Anywhere in the world.
No, Gafur Bhai, you have to show them your value. You have to show them value. Can you put out a notice board saying this hospital run by, let's say, Gafur Saab and Matai Saab has got no infection? Can you put it out? Nobody will put it out. You don't have the guts. I have the guts because I don't want to bury my name now. Show them that my use of meropenem in this hospital is zilch. Show them that I do not have any MDRO. I have a norm, maybe one or two coming in from outside. You guys and me are not in the advertising business. You have to sell yourself and show that you can do it. But why are we not doing it? I do not allow any HIV patients to die under my care today. Zero. Like that you have to promote. you're all very placid. You have to move to show me which other specialty in the hospital is placid like ID.
Right, right. No, that's a very valid point. We need to stand up. That's what Dilip ji is telling us. Stand up. Now, George, you need to intervene here.
Yes. I have three thoughts, Gafur. Of course, Dr. Dilip, Vasant, and you are saying there is plenty of money in ID, which I agree with. That's the first point. I mean, if you really want to generate money, you just have to think out of the box, and then you can certainly generate money. But the point is, which Tanu made, if you start comparing yourself with somebody else, there's no end to life, or there is no happiness, and you will always find people better than yourself. So don't do that. Your competition should be yourself. A better you, a better ID physician tomorrow than today. The whole perspective will change. Second thought. Third thought is, the money issue has been a recurring theme anywhere in the world. I'll give you an example where many of us are trained in the US. ID is probably one of the least income-generating specialties, unlike the procedure-oriented specialties like cardiology or gastroenterology. But ID is the most respected specialty across most of the hospitals which I have been to in the US, academic institutions and otherwise. I have been to several. The credibility, and if you have a problem, real problem to solve, call in the ID guy. Maybe leukocytosis of 12,000 or a little bit of a fever. They will sort it out for you. And the cardiology guys and gastroenterology guys, they will mint a lot of money, but they don't have the time to spend it. What are you trying to achieve? So you need to have a reasonable perspective as to why we chose ID. So it brings us back to the fundamental question: why did we choose ID? I chose ID because ID is a perfect blend of science, detective work, and purpose. I chose infectious disease because it combines the intellectual thrill of solving complex diagnostic puzzles with the privilege of curing patients, and also the opportunity to make a difference in the greatest needs of our country. Infections are still one of our major challenges. So I think this question each of us will have to answer ourselves. If you go after money, it's like chasing your own shadow. You will never be able to catch it. You turn around and walk, it will follow you. I think money is important, but money is not everything in life.
Thank you, George. As Lord Buddha told, desire is the root cause of all sorrows. Ram, when I joined Apollo, one of the famous orthopedicians told me, without Ram, many of my patients will be dead. But to my knowledge, Ram is still driving a Mahindra Scorpio, and that orthopedician has got a Land Rover Defender, a Mercedes S-Class, and a Bentley. What do you think of it, Ram?
First of all, I don't drive a Mahindra Scorpio. I drive a Tata Nexon EV, which is a much lower vehicle. But I'm perfectly happy, Gafur. As George said, as Tanu said, you don't go into ID for making the money. You go into it for the job satisfaction. I don't have to take the stress of the orthopedic surgeon when his surgical site is full of pus and the patient is putting a lawsuit against him, saying, how did this happen? In fact, in many of these cases, I'm the only guy who avoids the lawsuit because I go in and fix the problem and get the patient out of the hospital. So if I were interested in making money, I'd have become a cardiothoracic surgeon or a neurosurgeon. This is a worldwide phenomenon. It's got nothing to do with ID or India. If you are in a non-procedural specialty, you will make less money. The point is, are you happy? I think I'm happy. I take a lot of time off, as many of you may know. I'm very happy when I'm seeing patients. I'm blessed to be working at this age, although there are many older people than me in this group. So I'm quite happy, Gafur. I really not interested in a Land Rover at this point.
OC, thank you, Ram. OC?
Yeah, it's a fact. ID physicians don't make us cardiothoracic surgeons or neurosurgeons. See, you make a change. You make a change in the patient's life. One example, HIV. When I started my career, almost all my patients died, unless you are a long-term non-progressor or an elite controller. Now nobody dies, provided that person takes his or her pills. Infective endocarditis you cure, tuberculosis you cure. You help in making diagnosis in patients who have complex medical problems. The best history, best physical findings, best list of differential diagnosis comes from ID physicians. You make a difference at the level of the patient's family. When your PLHIV is able to get married and have a child who is uninfected, you have made a major difference. You make a difference at the level of the institution when you lead the AMSP programs, stewardship programs. The COVID pandemic, classical example. Even today, people meet me, and when I'm introduced, doctor, I saw your video. SIDS, thanks to Dr. Nambi, we have this series of videos where authentic, reliable information came from ID physicians. So even at the institutional level, ID physicians, at the state level, we know in Tamil Nadu how people from Apollo were involved in getting the guidelines. So you make a difference. But like everybody else said, George and Dr. Dilip and RGK, I think we make enough money. Meaning you need money, of course. You get enough to have a comfortable lifestyle. I think. I have to acknowledge here that all my life I have worked in a non-governmental voluntary setup, which is an academic medicine. So you get a comfortable salary, very comfortable salary. But
Thank you.
the gift, the satisfaction is in making a difference at the patient level, at the family level, at the institution level, and even beyond the institutions.
Thank you, OC. Thank you. Sunita, your opinion on the money?
Oh, I thought I started this discussion. Infectious disease will give you enough money to live. Like Dr. Ram goes from point A to point B, as well as the orthopedic surgeon goes from point A to point B. So what else do you need? Okay. And again, like if you really want to do something, if you want to earn more, I mean, what is the limit to how much you want to earn? I don't know how much each person makes, but each one I think is making enough to survive, not in poverty level, to be in a good, comfortable situation. When you're comparing with, there's no end to comparison. Okay. And again, this is not, if you want to do more, there are opportunities in ID to do further more beyond what you do as patient care. If you're not billing one-on-one for each patient, you can do more. You can get into other areas. You can get into administration. I don't see why more ID physicians are not getting into administration role. And that is a real pity, because we have all the expertise compared to any other field to get into administration. Why can't we get into administration? Why are we only talking about clinical care? We are better at, I think, compared to the other medical fields, we do more research. So why are we not getting into even pharma industry for that matter, getting into research. If money is the thing that you want, if that's what makes you happy, then get into areas that will make you more. Do whatever you do to the best. Once you do to the best, automatically money will follow. And you don't have to do it for the sake of money. If you do what you do to the best, automatically it will happen. And most of the people who are doing ID have a higher IQ than most other people and can do more in outbreak management or other things. You can get into situations like you can go work for WHO, you can go for work for other non-governmental or non-governmental organizations. There's a world of opportunities out there. You can be an entrepreneur, you can start your own setup, and you can start giving, take all the patients who need home antibiotics and take care of them. I mean, there are, if you want to do, you can want to succeed, whatever you want to do, you can still do it ethically. You don't have to go into unethical practices, and you can still do well. And if you want to do, okay, if you tell somebody who is going into a particular field that you're doing it only for the service of that, that's one way to look at it. But most youngsters would not be wanting to get into field just because of the service. You want to at least do what you want to do to the best. And ID is one field where you will be meeting all strata of life. So you will be taking care of the disadvantaged as well as the people who are in high strata, and your connections will be much better. So if you want to do something, please, that will help you. So
Thank you,
there's
Sunil.
no reason to worry about finances as a negativity. You have options. If you really want to do well, you will do well. And I know a lot of ID physicians who are doing much better than a lot of other physicians as well.
Dilip?
Dr. Dilip.
No. So, Dr. Sunita, I agree with everything what everybody is saying. Please understand, it's all just 1%. Just 1% job opportunities are available. Nobody is, that young Suryavanshi, how did he come up? That is a miracle. That's an outlier situation. You look at the Apollo systems. I have 15,000 beds. I have 18 ID specialists. How do you justify that? I have now CMC has 4,250 beds. How many ID specialists? I've got 8 and DMs. Now, how many hospitals are out there in the country, and we have 1 million beds? Now, how many beds per ID physician can they look after? I'm talking about hospital medicine. And how much salary do you want? With inflation, today's rate is 2.5. You cannot manage life without 2.5. If you want to begin life, if you got a double income, it's all right. But 2.5 is what is required to pay your EMI on home, EMI on your car, and students and children education. And if you don't have health insurance, or if you do not have money for, you have to set apart for your pension as well. So look at everything. 2.50, can you earn it? Yes, you can, provided you sell yourself well. Show the people that I am of that value. Brother, I'm 10 lakhs value to you per month. I'm charging you only 2.5. Show them the value. They will come running to you. We are not showing our value because youngsters, whoever is listening, I don't know who is out there. It's a beautiful profession. It is satisfying as people say it. You need to be with patient care. You have to work 9 hours a day, if not even 16 hours a day. I'm not a Narayana Murthy who says you must work 17 hours a day or something like that, 70 hours a week. But patient has to be under you, even though the patient is under orthopedics. Because we are not taking that responsibility. If you take that responsibility, I'll pay you more. That is where we fail. Please understand, youngsters, you've got to go to the lab. You've got to understand, speak to all the physicians, all the surgeons, nurses. You have to make friends. They will send you a leukocytosis. They will send you a fever of 100.5. That all builds up the business. Now you tell me, you have got 9 hours. How many patients can you see per day? I take 45 minutes to see a patient full, head to toe. I will make mistake. It's a general medicine patient. Even if he has an infection, I still go through the general medicine program. You have to commit yourself to that. And I charge 1,500. Now you tell me, if I put in my ID consultation to that, if I follow up every day, I get 750. You have to design your pay packet. Don't think that the hospital is out there telling you, Baba, I'll give you this much. You work for me this much. If there's no motivation, no incentive, you will fail. You will be jumping from hospital 1 to hospital 2, unable to satisfy your inner needs. You also got ego. Don't tell me people don't have ego. You have to satisfy that ego. You have to satisfy your future plans. Be realistic. I worked in CMC for 42 years. I'm not saying good, bad, or ugly. I've got my rewards. I got my let's say I got my rewards. I'm not regretting it. Given them a chance again, I will still work in CMC. But the next 15 years, I'm going to prove myself if I'm capable of getting any income on my own without any institutional support.
Thank
You youngsters must think like that. Don't ever think you got mentors or godfathers to give you money. You have to earn it.
Money is, yes, Dilipji mentioned money is very important. Of course, professional satisfaction is very important. Now, see, AMR Declaration Trust is not an organization of ID physician. That is, we have seats. But from an AMR Declaration Trust perspective, we need the best brains in the country to come to the specialty of infectious disease, because we are leading the AMR control in the country and global level. So, of course, remuneration is very important. We can have a discussion in the future, maybe in collaboration with SIDS. Let's carry on to the next topic. Another disruptive innovation, that is artificial intelligence, changing everything in the world. And we know AMR, AMSP, clinical infectious disease, everything. AI has a role. We know the positive aspects. We don't have to discuss that. We know that. But is there a negative aspect? I'll give you a background. A couple of months ago, Elon Musk made a statement. In 5 years, we don't need doctors anymore. And I started laughing. Maybe Elon Musk is exaggerating it. He doesn't know medical profession. You can't replace all the doctors in 5 years. True. Now, I'm interested in artificial intelligence. I'm working on AI. I'm developing AI tools. As we speak, I'm developing myself. I'm not using software engineers. I'm developing the logic engines. I started developing a comprehensive clinical antimicrobial stewardship, infection control, outbreak control tool, developed a comprehensive architecture. It took me several months to do that. I started developing the logic engines because a very comprehensive tool, started testing it. You know what I found? Because it's developed by an ID physician, and I gave my engine the intelligence of at least 6 ID physicians I closely know. It thinks like half a dozen ID physicians. Very smart. I started testing. Very smart. I got scared. I'm telling you the truth. I got scared. If you develop such tools, am I trying to make my own future generation or immediate, infectious disease youngsters redundant? I stopped working on it. I'm reworking on the logic engine. You know what I'm doing? I'm using the human in the loop concept. Anything, every step should be authorized by an infectious disease physician. I can't downgrade the capability of my device. I can only help the ID physicians to make them the supervisors of their AI tool. So that said, I'm very convinced about danger of such tool. It's not just radiology. Infectious disease is one specialty that will have an impact of artificial intelligence. We need the opinion from everybody. How can we make use of artificial intelligence rather than we are allowing AI to replace us to a big extent? OC?
Yeah, AI is, whether you like it or not, going to be part of all our lives. So where can we use AI? Anything which is repetitive, anything like other thing is that very complex things like a patient in the ICU with organ dysfunction who is septic, deciding the dose of drugs, adjusting for all the organ dysfunction, PK/PD parameters, drug interactions, etc., comorbidities, etc. It can automate a lot of things you are doing in the clinic. But what can AI not replace? Making a diagnosis in a complex pyrexia of unknown origin, a PUO, AI can take you up to a certain level, but there is still, maybe I am too naive to think like that. I think there are still the human element, the gut feeling of a seasoned physician, whichever field, it may not be ID. Then finally, it's finally an interaction between two individuals, a patient and a physician, he or she. And we know that the way you deliver the care, compassion, empathy, I know, I understand that machine can be taught to be compassionate and empathetic, but I still think that finally you long for a human interaction like that. And so I think so that diagnosis in complex cases, straightforward, it will diagnose pulmonary aspergillosis in an allergenic bone marrow transplant who is having bad GVHD. I'm sure it will do a very good job. But then complex cases and finally the process of delivering care, I think the human element is still important. But then if you don't use AI, you'll all be left behind.
Yeah, thanks. So that's a good perspective. Now, the only difference is we are all using general AI tools like ChatGPT, Perplexity, Claude, but that's a different game altogether. We are talking about the specialist AI tools which are trained. It's a very complex process to develop such AI tools, and they're very smart and intelligent. And we believe AI doesn't have consciousness. That's wrong, because there is enough evidence AI is developing consciousness, not just intelligence, the real consciousness. And radiology is one specialty that could be really already being replaced partly in several institutions. Of course, not interventional radiology. Today I was discussing with two, maybe neurology, but not neurology, because they have to check the reflexes, the sensation, the motor, which AI will not be able to do that. But ours is a cognitive specialty. And we are working in private hospital across the world, and they want to reduce the manpower, and AI can do a lot of, in future, will do a lot of the job that can be done by our specialty. Ram?
So the question is, do you think AI will take over ID as the ID physician's role? Not in the immediate future, not for sure. That is for sure. I really don't know. I'm not an expert on AI. I use basic AI in my practice, mostly for looking up stuff that I don't know, or what I used to do on Google search, I use AI for. I think as of now, infectious disease is too complicated for an AI to take over just the science part of it. And as Dr. O.C. mentioned, there is an art of medicine as well, talking to patients, counseling, history taking. One of the big problems that AI has is that it is only as good as the input you put in. And we all know that one of the critical aspects of infectious disease practice is taking a good history. So who takes that history? The machine can't take that history. Who's going to ask? For instance, you presented a case of amoebic meningoencephalitis last week. Who is going to ask that history? Did you go swimming in X body of water? Or did you have that high risk exposure? So only if you elicit all these things and feed it into an AI would it actually give you an accurate diagnosis. So I just don't think AI is there yet. I'm not an expert on AI. We'll see what the future holds. It's important for all of us to stay abreast with the literature, but not for the next decade. I don't see ID physicians going out of vogue. And actually, that has nothing to do with AI. Any other specialty, for instance, rheumatology, endocrinology, neurology, some of these non-invasive specialties, the science part of it may become increasingly AI oriented, but never the art of medicine. If I'm going to be told I have a life-threatening disease or an important medical decision, it has to come from a human being. So that part will never change.
Thank you, Ram. George, no, we all know the challenge of AI, but if we strategize, at least, our young ID doctors will not have the negative impact of AI. How can we strategize? How can we train them to be the masters of the AI? And what can we do in practical world in our ID strategy making?
Yeah, I think that's a good way of looking at it, The question is not so much about AI versus ID physicians. Because for the various reasons which have already been mentioned, it is more about AI-enabled infectious disease physicians versus those who do not use AI. I was just thinking about, I think, my pre-degree time in the 80s. There was 1 month strike and there was no college because the computers were coming in and the apprehension was a lot of jobs will be lost and we should not allow it to happen. I hope we have learned much more from those kind of experiences. It's not keeping AI out of our work. That should not be the strategy. The strategy should be how can we enable ourselves with the AI. What all will I do? 2 or 3 things. Number one, if you really look at AI-enabled clinical decision support systems, like Ram said, you still need physicians. You need to get the crucial history, the appropriate physical findings or the investigations, and feed it to the AI. When there are multiple decisions which are required, like Dr. Osi was mentioning, be it in the ICU where the patient is critically ill, there are several things going on. When there are multiple things going on, human decision-making obviously is not the best way. And these AI-assisted decision-making would definitely fare better. So I would think that the AI-enabled clinical decision support system will be a good area. Second is wherever you can automate a repeated task, right from triaging the patients to sending them to appropriate doctors, your billing, and a whole lot of things can, you can automate all that. And many things, what we do as infectious disease physicians, right from when you are talking to the patients today, if you really use the appropriate tools, you don't have to sit and type it again, take at least 15-20 minutes to type a history and physical findings. Most of it is recorded already, transcribed. We just need to make some corrections, make it appropriate. That's the way to go. And there are several other areas. So my suggestion to the younger colleagues is get yourself more and more supported with the AI and to make you a better physician in your endeavor to become an excellent ID physician.
Thank you, George. Now we will go to the next step. We know the disruption, AI, and every other challenge. We have got many other challenges. Let's ask what the profession should do now to shape the next 10 years. Vasant, I will ask you a question. Looking 10 years ahead, what will be the daily work of an ID physician will be, and which present day activities may disappear, and which new responsibilities may become central? Are infectious disease physicians in the future will do exactly what we do, or is going to be different?
I think to me looks like, I think of course infectious diseases are more clinician. So I don't think they are first they are clinician and then the diagnostics come into the picture. So I think the bedside clinical job which is there of a physician or a clinician, ID is very, very important. I don't think that is not going to change, because ID, first thing is he has to be a good internist. He has to be a good everything from every angle, and I don't think AI or anything is cannot replace a good clinician. So I think that is not going to change ever in future also. But having said about AI, so AI, we have to embrace AI. We cannot say that we cannot go without AI. So we have to be in pace with what's happening in the world. I think the role of a ID physician is going to remain the same. It's not going to change. Maybe with little diagnostics here and there, that might be usually helpful in over a period of 10 years time, I think. But I don't think so. How is the bedside clinical examination going to change? It's not going to change for next. I mean, I don't think it's going to change ever, because I think a good clinical history, everything, so many things to look into. You cannot replace that bedside clinician. That is not going to change for sure. I feel I have one statement to make, that people use robots in urology, people use robots in orthopedics. I feel ID physician is a robot of the hospital, because he corrects a lot of things which go wrong in the hospital. He corrects a lot of clinicians in different faculties which go wrong in there. And I think once I think all these your friends have full confidence in you, you become the robot of the hospital, because you correct and you think that I feel that is what how I look for next 10 years. You will become a robotic for the hospital. And I think the hospitals have to understand this is very important, because it is just not, it is a super support system of the hospital. It is a very, very, very important support system of the hospital. I'm telling you, if I leave suddenly one, it's going to collapse. It's a very important support system of the hospital. That's what I look at 10 years. It's going to be, the hospitals are going to be more and more and more dependent on the ID physician. Only thing I think we all have to make this prominence felt across India among all the hospital administrators. We should get them into the picture to understand what the ID physician's role is compared to they have a very narrow tunnel vision. The urologist will make money, the orthopedician will make money, but I think ID physician is the one who is the crux of the hospital. That's why I feel.
Right, Vasant. Now, Ashwini, what should young professionals do to ensure that hospital view them as essential clinical and strategic leaders than an optional? Currently, in many IDs, optional. What can we do to make it, we are the essential, the core part of the team?
There are a lot of ways. One is clinical acumen, and everyone is saying, having good collaboration with your other specialty colleagues, because then that makes you indispensable, or that gives them confidence that you are going to sort out their problem. So then you are irrepressible part of their routine workup, their routine management protocol. Other thing is being a part of infection control, because that is a way to reach to management, or being a good um, being in a good terms with the management. So infection control, antimicrobial stewardship, I doubt, but at least for projection's sake, hospital do want antimicrobial stewardship, and that definitely helps. So I guess these 2-3 areas, if we are part of it and we project ourselves. In addition, we should project ourselves differently. Like, I completely agree with Mathai sir. So to start with, even I followed RGK sir's advice and don't do medicine practice and all that, and just do ID. Don't we hardly admit a patient under ourselves. But I guess if we start admitting patient under ourselves, it's an extra burden. But then it's a chain, it's an organic growth. So once you have one patient, that generates the other patient, and that gives that confidence that yes, ID is solving their problem. It gives you extra edge, extra control, that whatever you want will be followed. You don't have to rely on someone else who will follow your advice to the extent he wants. So yes, I guess it's a mixed bag. Again, depends on the place where you are working, where you're working at a corporate place, where you're working at the individual hospital. You have to modify it as per your choice.
Now, all of you, George, Sunida, Tanu, everybody, you are all doyens, you built the specialty. Do we need a strategic change so that will help the young infectious disease physicians of the future, their survival, their benefit? Should we need a strategic change?
So, I think we are doing that right now, because ever since the Clinical Infectious Disease Society has come into being, we are doing these SIDS conferences, we are doing webinars, we are training our clinicians well, because I think finally what is going to help these youngsters grow is if we make them good physicians, we make them good ID specialists, and that is how they are really going to do well, because nothing can replace knowledge and acumen. So if we train them well, and that I think is going to be the best way to grow the specialty or make these youngsters indispensable in the hospital where they practice. And another thing which I would like to say through this medium is that your growth as an ID specialist takes time. So people will have to be patient. I mean, all of us here have taken at least 5 or 10 years to establish ourselves. So that people should be prepared for that kind of gestation period. It takes time, and that is okay. And another thing which I would like to say is that ID is a very, very difficult specialty, because things keep changing, cases are very complicated, and it's a new challenge every time. So even though I may have practiced ID for 25 years, there are times when I see a patient and I don't know what it is, and I have to either go back to the internet or call up my teachers to find out. So it is not an easy specialty, and you are always learning, even though you may have been there for 25 years. So I think the youngsters should recognize that it's a difficult specialty, it's a cognitive specialty, and it is a specialty where it takes a long time to grow. And the best way to do well is to work hard and acquire knowledge, and there are no shortcuts.
Yes.
In ID specialty, if you want to convince administration, or if you that you're doing something good and you need to be valued, it's not sufficient if you're going to just see one patient at a time. You have to be able to show that in numbers. Admins see only numbers. If you're going to say that, yes, I'm helping this patient and I'm helping that patient, it doesn't help. You have to say, okay, we were able to reduce the length of stay, we were able to reduce the antibiotic usage, we are able to reduce so many post-op infections, we're able to reduce. You have to be able to show that to the administration. You can't just keep telling that, yes, I'm doing a good job, I'm doing a good job. Only you know that. For them, they will not see that. You have to be able to put that in the language that they can see. And when we're talking about antimicrobial stewardship, the other way they will look at is, okay, you're decreasing the amount of money that I'm generating by cutting down the antibiotic usage. What good does it help me? So we'll have to tell them that, yes, by decreasing the infections or whatever, you're decreasing the length of stay, but I'm bringing in more patients so that revenue per patient will be more. You have to be able to convince the admin that you're doing this. You have to, the value that you're generating needs to be brought out. Like Dr. Tanu was saying, starting with AMR, infection control for an ID physician makes a huge difference in that establishing your relationship with the administration and also with your peers. And it will also be a stepping ground for you to get into other positions. Yes, clinical work is good, but if you're able to do more than clinical work plus something more, it's definitely beneficial for both the patients as well as the clinicians and the organization. So you need to start thinking of more beyond that particular patient that is in front of you today. What can you do for the system and not just for that particular patient?
Thank you, sir. Dilip?
Yeah, I want to very quickly answer two things, and then I will. First one is have a look at the big picture. I have 812 medical colleges, and I have 1,18,000 seats every year. Let's say 1 lakh per year. Then I've got 44,000 postgraduate seats, and then I've got super specialty seats of about 8,000, of which ID may one day occupy 1,000 or 1,500. We have got 10 lakh beds in this hospital. Let us say average length of stay is 4 days, including the government hospital. Remember, very easy to calculate. A medical college requires 700 beds to run efficiently. So I've got 800. So that itself is 5,60,000, and the remainder is the corporate hospital. Do ID specialists have a role in the government medical colleges? Very few government medical colleges are accepting ID as a specialty. That takes a huge chunk of possible, let us say, possible employment opportunities. Secondly, when you've got this many corporate hospitals and this many beds, and the so-called AI, which Dr. Ghafoor, if you permit me to just say a few minutes on this AI issue, will it threaten my job? The question here is, as Dr. Ram said, about in terms of getting the history. Today, with portable electronic health records, you can carry your health history wherever you want and go for. The biggest business is going to be second opinion. I do second opinion on some of the Apollo cases as well. And I send them back to the Apollo system. I don't know about CMC. They see me and they go back. I'm not saying that I'm making the correct decision. They themselves look at it and say, yes, two great minds have thought like this. Please understand that. Second opinion is going to be your biggest windfall. So beds, government hospital has to start IDs. There is no increased fees for super specialties. Many super specialties like cardiothoracic surgery is going begging. ID will not go begging because I've got internal medicine to back myself up. I'm worried about microbiologists and ID joining together, because make sure that your general medicine is very strong. Otherwise, you will have a fallout. You will certainly get your 3 lakhs as you want. You will certainly get your respect. You will certainly get your piece of satisfaction, etc. Now, coming to AI, I talked about electronic health records, and they will all carry it. But please understand that you have to initially start with a syndrome. Even if it is an antibiotic-related problem, you have to start with a syndrome. The syndrome is intra-abdominal abscess. The syndrome is cholangitis. The syndrome is community-acquired pneumonia. Who gets the database? When I was in CMC, I had 6 interns, 4 registrars getting the history for me. They were my AI. They were giving me the data which I was processing. Now that is all going to be machine process. So you please understand, my 45 minutes will go for that. And I'm giving a primary opinion. He or she can take it to someone else for a secondary opinion as well. I don't know how many may be taking mine as second opinion, but please understand. The second part is, you know about antimicrobial resistance only if the microbiologists grow the organism. If they don't grow, you are zilch. What is your starting point then? If you don't have an organism, what is your starting point? Now, that is the difficult part. If you got the organism, you're in Eureka, you can do anything you want. 80% of the bloodstream infections, you're not getting an organism. Maybe it is viral. I'm not challenging it. Maybe it is fungal. You've got all the automation available. You're still not sending 3 blood cultures. You're still not growing the organism. You're still giving empiric antibiotics. Whatever the reason being, the microbiology automation or the microbiology's diagnostic success rate has to improve if the infectious disease have to survive. Or infectious disease, people will have to run the microbiology. The next part of it is, now, most important in AI is only the probability distribution. That is all AI can tell me. Has this patient had prior colonization? Has patient had previous prolonged ICU stay? Has the catheter been in for more than 5 days? You can have so many of them written down. Look at the risk factors in any study and add all those risk factors, and you have to say no, yes, no, yes, no, yes, no. Only then will that give you a probability distribution. Once you have the probability distribution, then you have to, if you got the organism, easy, go for the CARBA assay. If you don't have the organism, what are you going to do? Still, you're intelligent. AI cannot help you. AI cannot only give you probability. You still have to make a choice. There again, it's for the choice. If it's for the quality of the decision that you are being paid for. I keep telling my people, please give the reason why you are saying that this organism is circulating and this antibiotic is the most appropriate. You make people understand, brother, he's a genius, depend on him. That's all I want to say about ID. Don't ever think that ID as a, because you can, it's like any other profession. Cardiologists of no value if he cannot read ECG, no value if he doesn't have an ECG, no value if he cannot do echo. These are the concepts. So ID as a specialty, same as cardiology as a specialty. Today, I can do cath, 15,000 rupees. Previously, at that one time, it was 50,000, 1 lakh. If I put a stent, it's 50. The money is coming down, even in those specialties. That's all I have to say. So all specialties equal infectious disease, you have to raise your standards. That's my bottom line.
Dilip ji gave a solution too. Infectious disease physicians can give second opinion to AI primary opinion in future. So that's a very good opportunity too. Now, all of you, the closing question will be: all of you are legends in infectious diseases. You create a legacy. Now, what you expect the next generation of the 10 years? What is the one legacy you hope the next generation will create during the next 10 years? Ram?
The next generation is actually going to be at the interface of traditional clinical generation and AI. I hope the next generation retains the clinical skills. What I have seen among some of the juniors is they rely too much on technology, too much on tests. They forego their clinical skills, especially in history taking and probabilistic reasoning, and rely on tests which are often misleading. I hope with proper mentors, you don't develop those habits. But I would like to tell the younger generation, please go into ID. It's a great place to be in. I don't know of any good ID physician who either doesn't make a lot of money or is very satisfied, or who fundamentally, is a very respected person. If you're good, you'll be respected, you'll make money, and you'll have a great time in life, and you can use your brain all the time. Please go into ID. Don't worry about the money. There's plenty of it there if you're good.
Thank you. Thank you, Ram. George?
Gafur, I think one of two things I would say. Number one is the becoming the legacy which I would like to have in ID physicians in the future is, number one, looking at the whole the different aspects of an ID physician, which is ID physician is essentially a diagnostician. They are clinical leaders. They are epidemiologists. They are researchers. Now, these days, you would see that you are somewhere. You've somewhat succeeded in getting them to think like an ID physician, become a good clinician. But I think the other aspects which an academic ID physician or a leader in infectious disease would require, including the research, answering our own relevant questions. I would like the next generation to get into some of those aspects which will really make a difference in the future, is what I think.
Thank you, George. Vasant? Please unmute, Vasant.
So I think the clinical thing, as I've been always saying, cannot be replaced. But AI, as my son has taught me, AI is time revolution. And I think earlier we used to, if you want to read chapters or make this thing, it used to take days together, to read a chapter and, look into this. So AI, I feel, is time revolution, and AI is going to be good support system for a clinician, but it has to be used judiciously. That's very, very important. And I think AI, another thing is, I think ID, I always look at it as mathematics. Though people say medicine is 2 plus 2 is not equal to 4, but in ID, I always feel that if you go systematically, 2 plus 2 becomes 4. And because ID always looks at the right diagnostics, or right, to get to the core, the diagnosis for the patient. So I always look at ID as 2 plus 2 is equal to 4 by subtracting many of the other things which are not required. So I think clinical will never be replaced in ID. A good clinician, good ID physician will be always good clinician, but he has to take AI, which will be a time revolution for him.
Thank you, Vasant. Tanu?
So I think I would like to echo what Dr. Ram said, RGK said, that, I wish that the new generation would, would make ID care also affordable, because right now it's a lot of investigations and a lot of expensive medications. So how to, try and arrive at a clinical diagnosis and use investigations very rationally, and try and see how you can deliver the best possible care at the lowest possible cost. That is what I would like to see in our new generation.
Thank you, Tanu. Sunita?
I would like to, the one time that I get the most satisfaction of having treated somebody, the one that tops the list is when I'm taking care of somebody, that patient dies, family comes and thanks me for taking care of their loved one. So that is one place where I feel that I have done a good job. So if I'd like to tell my students to have the empathy when they're taking care of people, take care of them as human beings holistically, and there is that satisfaction you will get when patients' families come back and thank you is really something that you want to get. It's like when you get better, everybody will come and say thank you. You've done a good job. That But when somebody dies and the family comes back and tells you.
Thank you, Sunita. Any other comments? We had a wonderful discussion. Anybody?
Yeah, just one more thing. Please don't forget specific population. The geriatric age group is increasing. You've got to change yourself and call yourself infectious disease plus geriatric physician. Please understand this. Public perception should improve, because infections is the number one for the geriatric age group. Number two, oncology is improving, and there everybody ends up with fever and need an infectious disease consultant. So link up with them. Third one will be transplant infections. I'm not so much about tropical infections and all of the other things. These three, and then the bioprosthetics ones. So these are the areas that are increasing. So you keep reading. Nobody mentioned about writing skills. Nobody mentioned about research skills. How do you advertise yourself? It's only your writing skills. My HDL cholesterol has never gone beyond 40. Why? Just now the H index has just crossed 40. So now you see now what is more valuable to me, my HDL cholesterol. I would love it to be more than 40, but it's not going up. But concentrate on your research publications, concentration on writing skills, teaching skills. These are all important. That is where the legacy you will leave behind, and the guys will join you so that you can pass on this. Hope that these people will pass on the legacy to their followers. That's all I have to say. Thank you.
Thank you, Dilipji. We had an amazing discussion. As I already mentioned, AMR Declaration Trust is an organization working in the field of AMR. We organized this particular webinar because we believe infectious disease physicians are one of the most important professionals in the tackling AMR world. And we want the next generation of infectious disease physicians not just surviving, but flourishing. So we would like, as a member of the SIDS, may I suggest SIDS to take this discussion forward in a bigger way so that we can have a powerful, influential, and a very good infectious disease community in the country to support us in the tackling AMR efforts. Thank you very much for all the panelists. You're all the doyens in the field of infectious disease, icons in the field of infectious disease, who built this specialty, established this specialty, real icons for the young infectious disease physicians and the future infectious disease physicians. Thanks a lot and good night.
Thank you. Thank you.